Lactose intolerance. Nihal K. Patel, MD. Basics. Description. Lactose intolerance is a syndrome of abdominal pain, bloating, and flatulence after the ingestion of lactose. Lactose malabsorption results from a reduction in lactase activity in the brush border of the small intestinal mucosa. Lactase activity peaks at birth, then decreases after the first few months of life, declining continuously throughout life. 75% of adults worldwide exhibit a decline in lactase activity after birth. Only 50% of lactase activity is needed to digest lactose without causing symptoms of lactose intolerance. Congenital lactose intolerance, very rare. Primary lactose intolerance, common in adults who develop low lactase levels after childhood. Secondary lactose intolerance, inability to digest lactose caused by any condition injuring the intestinal mucosa, e.g., infectious enteritis, celiac disease, eosinophilic gastroenteritis, or inflammatory bowel disease, or a reduction of available mucosal surface, e.g., resection. Lactose malabsorption may be asymptomatic and is equally common in healthy patients and in those with functional bowel disorders. System S. Affected, endocrine/metabolic, gastrointestinal. Pediatric considerations. Primary lactose intolerance begins in late childhood. No consensus on whether young children, 5 years of age, should avoid lactose following diarrheal illness. Lactose-free formulas are available. Exclude milk protein allergy. Epidemiology. Incidence greater than or equal to 50% of infants with acute or chronic diarrheal disease have lactose intolerance, particularly common with rotavirus infection. Lactose intolerance is common with giardiasis, ascariasis, irritable bowel syndrome, IBS, tropical and non-tropical sprue, and AIDS malabsorptive syndrome. Prevalence in South America, Africa, and Asia. Rates of lactose intolerance are 50%. In the United States, the prevalence is 15% among whites, 53% among Hispanics, and 80% among African Americans. In Europe, lactose intolerance varies from 15% in Scandinavian countries to 70% in Italy. Predominant age, primary, teenage and adult. Secondary, depends on underlying condition. Predominant sex, male equals female. Etiology and pathophysiology. Primary lactose intolerance, the normal decline in lactase activity in the intestinal mucosa is genetically determined and permanent after weaning from breast milk. Secondary lactose intolerance, associated with gastroenteritis in children, also associated with any gastrointestinal infection or inflammation of the small intestine with resultant lactose malabsorption in both adults and children. Genetics. In whites, lactase deficiency is associated with a single nucleotide polymorphism, SNP, consisting of a nucleotide switch of T for C13910 BP on chromosome 2. This results in variants of CC13910, lactase non-persistence, or CT13910/TT13910, lactase persistence, 1. SNP, C/T13910, is associated with lactase persistence in Northern Europeans. Other SNPs, G/C14010, T/G13915, and C/G13907, have been linked to lactase persistence in some patients of African descent. Risk factors. Adult onset lactase deficiency has wide geographic variation. Age. Signs and symptoms usually do not become apparent until after age 6 to 7 years. Symptoms may not be apparent until adulthood, depending on dietary lactose intake and rate of decline of intestinal lactase activity. Lactase activity correlates with age, regardless of symptoms. General prevention. Lactose avoidance relieves symptoms. Patients can learn what level of lactose is tolerable in their diet. Commonly associated conditions: tropical or non-tropical sprue, giardiasis, IBS or other functional bowel disorders, small intestinal bacterial overgrowth, SIBO, celiac disease. Diagnosis: lactose intolerance can be presumed in patients manifesting mild symptoms after ingestion of significant amounts of lactose, such as greater than 2 servings of dairy per day, with resolution of symptoms after avoidance of lactose-containing foods for 1 week. A positive lactose hydrogen breath test is confirmatory. Lactose intolerance can mimic symptoms of functional gastrointestinal disorders. Lactose intolerance can also be a coexisting condition. History: assess daily lactose consumption. A single dose of lactose, 12 grams, equivalent to 1 cup of milk, consumed alone produces no or minor symptoms in persons with lactose intolerance. Lactose doses of 15 to 18 grams are well tolerated with other nutrients. Doses greater than 18 g cause progressively more symptoms, and quantities greater than 50 g elicit symptoms in most individuals. Symptoms arise 30 minutes to 2 hours after consumption of lactose-containing products. Symptoms include bloating, flatulence, cramping, abdominal discomfort, and diarrhea or loose stools. Vomiting may be noted in adolescents. Abdominal pain may be crampy in nature and often is localized to the periumbilical area or lower quadrant. Stools usually are bulky, frothy, and watery, although diarrhea may be rare in adults. Only 20–30% of individuals with lactose malabsorption develop symptoms. Physical exam: vital signs and general appearance are typically normal. Audible bowel sounds, borborygmi, on physical examination, may be particularly bothersome to the patient. The exam is otherwise typically normal or nonspecific. Differential diagnosis: functional GI disorder, e.g., IBS, SIBO, celiac disease, inflammatory bowel disease, infectious enteritis such as giardiasis, drug or radiation-induced enteritis, sucrase deficiency, cow's milk protein allergy. Diagnostic tests and interpretation: initial tests, lab, imaging. The lactose breath test, LBT, is a confirmatory for lactose intolerance. It is non-invasive, easy to perform, sensitivity 78%, specificity 98%. 2. Intestinal bacteria digest carbohydrates and produce measurable hydrogen and methane in expired breath. Administer lactose when fasting, 2 g/kg, max dose 25 grams in children, 50 grams in adults. Note any symptoms, sample breath hydrogen at baseline and at 30-minute intervals for 3 hours. Compare post-lactose and baseline values. A rise in hydrogen concentration value of 20 ppm over baseline is diagnostic for lactose malabsorption. An early peak, 15 to 30 minutes, suggests SIBO. Small bowel biopsy for histology and direct measurement of lactase activity, rarely needed. A positive LBT confirms lactose malabsorption but does not determine etiology. Diagnostic procedures / other lactose tolerance test is an alternative to LBT in adults and measures lactose absorption through serum glucose measurements. Following oral administration of a 50 g test dose in adults, 2 g/kg in children, blood glucose levels are monitored at 0, 60, and 120 minutes. An increase in blood glucose of 20 mg/dl, 1.1 mol/L, with the concurrent development of symptoms is diagnostic. False negative results may occur in patients with diabetes or bacterial overgrowth. Stool electrolyte testing, if done, may indicate a stool osmotic gap greater than 125 mosm/kg, although this is not specific to lactose intolerance. Test interpretation: low lactase enzyme activity in intestinal mucosa, tested by small bowel biopsy, may be patchy or focal. Treatment: there is insufficient evidence to recommend any particular treatment, including probiotics, colonic adaptation, and other supplements, as definitive first line. In the absence of a correctable underlying disease, treatment includes 4 general principles. 3b. Avoid milk/dairy products to improve symptoms. Up to 12 to 15 grams of lactose can be tolerated in without significant symptoms, 1 cup of milk. Gradually reintroduce lactose as symptoms allow. Spreading lactose servings throughout the day improves tolerance. If symptoms persist, substitute fermented and matured milk products for lactose. Certain strains, concentrations, and preparations of probiotics may alleviate symptoms. Incrementally increasing doses of lactose to induce adaptation have limited success. Insufficient evidence to routinely recommend lactose-reduced or hydrolyzed milk, lactase supplements taken with milk or probiotics. Maintain calcium and vitamin D intake. Medication first-line lactase, Lactaid, Lactrase. Commercially available lactase preparations are bacterial or yeast beta-galactosidases. Take 1 to 2 capsules or tablets prior to ingesting dairy products. Effectiveness at preventing symptoms varies. Can add tablets or contents of capsules to milk, 1 to 2 caps/tabs per quart of milk, before drinking. Also commercially available in milk in some areas. Not effective for all people with lactose intolerance. Complementary and alternative medicine. Certain probiotic formulations taken with meals may alleviate some symptoms of lactose intolerance. 4b. Ongoing care. Diet. Reduce or restrict dietary lactose to control symptoms. Patient-specific trial and error. Yogurt and fermented products such as hard cheese are often better tolerated than milk. Supplement calcium, e.g., calcium carbonate. Prehydrolyzed milk, Lactaid, is available. Patient education. Read labels on commercial products. Milk sugar is used in many products and may cause symptoms. Patients may tolerate whole milk or chocolate milk better than skim milk. Slower rate of gastric emptying. Lactose consumed with other food products is better tolerated than when consumed with milk alone. Primary lactase deficiency is permanent. Secondary lactose intolerance usually is temporary, although it may persist for months after the inciting event. 20% of prescription drugs and 6% of over-the-counter, OTC, medicines may contain lactose as a base. Most patients with lactose intolerance or malabsorption can tolerate 12 to 15 grams of lactose per day. Prognosis. Normal life expectancy. Symptoms can be controlled through diet alone if lactase tablets are ineffective. Complications. Calcium deficiency. Avoidance of milk and other dairy products can lead to reduced calcium intake, which may increase the risk for osteoporosis and fracture.